Modes of ventilation. Now, this is how the ventilator is going to determine the breath that it's going to give. And we have different ways that they're set up. For the most part, under normal circumstances, you'd see patients on volume control, which means we tell the machine to deliver a breath that is X number of milliliters of air. The machine would give, let's say, 500 milliliters of air, and it would cycle off and allow for exhalation. Now, in a patient who had normal lung compliance, as long as we're able to take in the air that we want them to, so long as the patient was able to exhale, the volume control ventilation would be a viable and good option. Now, in acute respiratory distress syndrome, apparently in COVID-19, and in patients who have severely decreased compliance, pressure control might be an option. When we can't push in the amount of breath that we'd like to, pressure control is a good option because it allows us to tell the machine how much pressure or how much back pressure we're willing to accept before it cycles off. So if we told the machine to inflate the patient until it felt 35 centimeters of pressure, centimeters of back pressure, then cycle back. Now, however much that was, be it 50 milliliters of air or 750 milliliters of air, the machine would not cycle back and allow the patient to exhale until it reached that number. Pressure control might be very useful with COVID-19, and it is very useful with acute respiratory distress syndrome. Now, we also have weaning modes. The ideal place for an endotracheal tube to be is outside of the patient. We want to get the patients off of the vent as soon as possible. With that said, we want to make sure that they're ready to be extubated, and we want to make sure that they're not going to have to be re-intubated. Now, weaning modes allow us to see how a patient would breathe, assuming that tube wasn't there. It's a good way of knowing how the patient is going to do if we extubate. Now, there are no sure things with extubation or with weaning modes, but they are a good way to determine without actually extubating our patient. Finally, some of the newer machines have smart modes, and we're not going to talk about those because there are a wide variety of them, and your pulmonologist and respiratory care teams are going to be familiar with them, but I wouldn't be able to touch on how many smart modes there are. Each company has its own way of doing this, and I don't want to discuss these because they're not something that you're likely to be coming across, especially during this pandemic.